Great. What a great pleasure to be here, and what a great day it is to hear about all this work in one place and one time. And what I'm going to do for the next 10 minutes is talk with you about cross-cutting work across the BRC that centres on qualitative research and using qualitative research methods to good effect. I'm also going to give you an example of the qualitative research that we do within the surgical innovation theme, which is the theme that Jane and Barry have just spoken with you about. And that's all going to be in about 10 minutes. So when we designed the BRC, we thought really clearly about the track record of excellence in our research at Bristol. And something that really stands out in Bristol is the excellent qualitative research that's been done here over many years. And a particular highlight of that is the work that's been led, of course, by Professor Jenny Donovan, particularly into trial recruitment, trial processes, and participant retention in trials. So when we thought about the BRC as a whole, and we thought about the 5 topic areas within the BRC, we thought about how we could embed qualitative research across all of those. And what we chose to do was establish a network of qualitative researchers that would work within the BRC and reach outside the BRC and establish ourselves as a network of excellence for qualitative research, building on the existing track record. So I thought today what I'd do would be talk a little bit about what qualitative research is and talk a little bit about the network and then give you an example. So when I think about qualitative research, I think about it as a means of providing explanations for how and why things happen. And it can complement and enhance other research methods. When we do qualitative research, we focus on what people do, their practices, and we also focus on what people think. And we join these two things together to think about how thoughts impact on what people do. And we also think very carefully about the context in which people do the activities that they do, whether that's a hospital context or a broader society and cultural context. We also use enormously robust methods in qualitative research. So you heard earlier today that qualitative studies are often quite small in terms of their sample sizes. And when we think about qualitative research sampling and analysis and the approaches that we use, all of those are thought about very carefully and in a very robust fashion. So if you hear about a sample size that's maybe 16, 20 or 30 participants in a study, you can be confident in a qualitative study that that's been thought about and is fit for purpose for the questions that are being asked. The other thing I wanted to say by way of background about qualitative research is that good qualitative research goes beyond providing simply description of what happens and how it happens. Good qualitative research delves into theory, and the theory and the approaches within qualitative research have an enormously long history behind them. So I'm a social anthropologist by background, and my founding father, if you like, from my discipline, was Malinowski, who was doing observational qualitative research at the very beginning of the 20th century. So we've got a long history behind us and behind the methods that we use. So the methods that we use and the methods that we're using across the BRC include observation, which might involve watching what happens in hospitals, or it might involve audio recording or filming what happens in clinical practice. We also do one-to-one interviews. You've heard about some plans for those earlier today. And we do focus groups, which bring people together to talk about and share their experience, and sometimes to build consensus between them. We also like to be enormously efficient in what we do, so we bring together evidence from existing research and we synthesize that, and very often what we'd also do is we look at existing data sets that we've so painstakingly collected over the years, and we reanalyze those again to get kind of maximum value for the data that it takes us a long time to collect. The kinds of analysis that we do include narrative synthesis. You heard about that from one of the PhD candidates earlier today. We do the secondary analysis that I just mentioned, and we use approaches that are generally thematic. We might use a framework approach. A lot of these approaches are based on a grounded theory approach, which hails from the late 1960s. And fundamentally, what they all involve is picking out the key thematic areas and topics that occur in our carefully collected data sets. But I also thought it was important to pause and think about what qualitative research has done for us. I'm not sure if you'll get the reference there. That's a picture of the Roman baths in Bath, where I live. And when I was thinking about this slide, I was thinking of the Monty Python sketch Within the Life of Brian, which asks, what have the Romans ever done for us? And the answer to that question is that they have provided sanitation, irrigation, medicine, and all sorts of other things which are crucial to the foundations of our civilization. So when I think about what qualitative research has done for us, I think about qualitative research as really fundamental to a lot of the applied and translational research that we do. So qualitative research has made our clinical trials better. It's made us able to design outcome assessments that are fit for purpose, appropriate and acceptable. They've enabled us to design really high-quality interventions, and I'm going to share with you an example of some of the design work we're doing. Qualitative approaches have also enabled us to think about how we can implement effective interventions into practice. And a growth area in recent years has been something called implementation science. And I'm a great advocate of implementation science as a way of thinking about how we can embed effective interventions into practice within the NHS. And qualitative work now uses implementation science to think about the different categories that have to be in place to enable embeddedness to happen. So I want to pause there because I'd like to move on to share with you an example of some of the qualitative research that we're just starting to do within the BRC. And this is work that's in the surgical innovation theme, and it's work that's led by myself and by my colleague, Dr. Katie Whale, over here, who is working with the musculoskeletal group within the surgical innovation theme itself. So one of the pieces of work we've been very proud of over the years in Bristol is our work on joint replacement. And I've been happy enough and grateful to receive funding from NIHR for a large programme of work to look at outcomes after knee replacement. And this really matters in the landscape of healthcare because around 70 to 80,000 people a year in the UK will have a knee replacement. The reason why they have a knee replacement is in order to relieve pain and improve function. The average age of knee replacement is about 70 years, and what it involves is removal of a knee which is causing problems because of changes in the cartilage and bone and soft tissues, and replacement of that knee joint by a prosthesis. And what you can see here is a screenshot from NHS Choices from a really nice animation that's available online, which demonstrates the process of a total knee replacement. But one of the problems with knee replacements is that although they're enormously successful for many, many people, for around about 20% of people who have this operation, there will be long-term pain afterwards. So if you look at pain 3 and 6 months after a knee replacement, there will still be a lot of people who will be living with ongoing pain. And that's an issue because people have knee replacements in order to relieve pain in the first place. So we're enormously interested in how we can improve outcomes for these patients. So what Katie's been doing in her work is looking at what kind of interventions we might develop that could sit alongside the surgical intervention of a knee replacement. And I wanted to ask the audience today, who slept well last night? Okay, so I'd infer from that that maybe quite a few of you didn't sleep so well last night, yeah? Okay. I wasn't going to ask who has knee pain, but what we do know is that there's a link between pain and sleep quality. And this is a bidirectional link. So if you don't sleep so well, you might have more pain, and if you've got pain, you might not sleep so well. Okay. And this is due to a variety of things going on within the body, within our psychology, and we might find that if we're not sleeping well, we have increased sensitivity to pain. We might find if we're not sleeping well, we've got increased inflammation. We might also have increased sensitivity in a subjective manner to pain, and pain is, of course, a subjective sensation. Overall, increased pain causes difficulty sleeping. It causes difficulty getting to sleep, remaining asleep, and also it affects sleep quality. We know that for people going through knee replacements, that problems sleeping are not great for outcomes in the immediate period after surgery. So we know that in the period of a few days after surgery, if you're not sleeping well, you're likely to have more pain after your surgery. We also know that that can have a long-term effect on how well you do in terms of your recovery in various aspects. Okay. There has been some work in this area, and a small clinical trial of 148 people has shown that there's a relationship between improved sleep and quality of life and pain outcome 2 weeks after surgery. But what we're interested in within the BRC is how to improve long-term outcome. We're interested in improving pain and well-being and satisfaction in the longer term after surgery, because this is a major operation designed to give people long-term benefit. So what we're doing in the qualitative work within the BRC network of qualitative research is we're following a process called intervention mapping to design an intervention for sleep that will sit alongside knee replacement surgery. And this is a very busy slide. I don't expect you to be able to read the content of it. But in brief, what it's saying is that a good approach to an intervention design is to establish what the issue is, use the existing literature, use existing data sets, in our example, qualitative data sets, to think about what's needed to improve an outcome. From there, conduct qualitative research, and Katie's going to do focus groups with people who are experiencing the problem that you want to address. And then from there, work with patients and clinicians to refine the intervention so that it's as good as it can be, as fit for purpose as it can be, and acceptable to them. From there, what Katie will do will move on to design a randomized trial with pilot work included in it to assess the effectiveness of a sleep intervention that will be probably for people before and after a knee replacement operation. So that was all I wanted to say about the work that we're doing. Hopefully it's given you a flavour for what qualitative research is for the network as a whole. It just remains for me to thank the Qualitative Research Network colleagues who are named here, and all of whom work really effectively together to share practice, to share ideas, and to share learning. Thank you very much for listening, and I'm happy to take any questions.